Everyone. Hola, bonjour, guten Tag. I'm Dr. DePhillips. I'm an assistant professor at the University of Delaware School of Nursing and the Nurse Fellow for the Global Consortium on Climate and Health Education. I welcome you with great pleasure today to session 7 of Nursing on the Front Lines of the Climate Crisis, Education for Action. Today's topic is on degraded air quality and wildfires.
Oh, Michelle, you've gone muted.
Can you hear me? Before we begin, a few housekeeping reminders. I encourage you all to refer to the website listed in the chat. Here you'll find the course objectives along with the course schedule and very detailed information about session resources. I encourage you to attend all 10 of the sessions as the information does build upon each other. Attendance. Attendance confirmation for all participants will be provided for both live and asynchronous participation. For live attendance, individual attendance is automatically recorded when you join the live Zoom session, but your attendance is not counted if you join with a colleague's link. For asynchronous attendance, video recordings and previous sessions are available on the Alliance of Nurses for Healthy Environments platform. That is learning.envirn.org. For continuing education for United States-based participants, in order to receive CE, and you can obtain 1 CE per webinar, participants must attend the live session webinar or view the recording and receive at least an 80% on the post-session evaluation. Following the webinar, attendees will be directed to Annie's platform to access this webinar recording and the post-session evaluation. Participants who attend the live session will be provided with a password, which allows you to bypass the video viewing requirement. This is the email that you're going to get, what it looks like. And as you can see on the right side, these are the dates that the previous passwords have been sent. So please also remember to check your spam folders for that password. You can get a certificate of participation separately from the continuing education credits. These are for participants who attend at least 7 out of 10 of the sessions, either live or via the recording, and pass the final exam with a score of 70% or higher. It is mandatory to join all Zoom classes, watch recordings, or take any post-tests and surveys using the same email address. Session logistics. Each session is an hour long. Sessions will end with a question and answer section. Please remember to put your questions in the Q&A function in Zoom and not in the chat. And as a final reminder, all of the recordings, slide decks, and resources are still available on our course website, so please check the chat for that link. Now it is my great pleasure to introduce our speaker today, Raluca Radu. Raluca Radu is a proud nurse who holds a Master of Science nursing degree from the University of British Columbia, with a focus on climate change and health education. Since starting her nursing career in 2014, she's worked in public and private healthcare contexts, particularly on surgical units, the emergency department, primary care, and with the occupational health and safety. She also had the pleasure of teaching as both a clinical instructor and lecturer at the University of British Columbia, where she played a key role in the School of Nursing as a content expert on climate change and health. Raluca's passion for the environment leads her to remain actively engaged on provincial and national levels as a member of the Canadian Association of Nurses for the Environment. Her role as a climate and health educator at Doctors Without Borders, Médecins Sans Frontières, where she led international-wide capacity building health co-benefits of mitigation. Raluca joined the Providence healthcare system in Vancouver, Canada as the organization's first planetary health lead. Raluca believes that healthcare systems are perfectly positioned to engage in climate adaptation and mitigation action on all levels to safeguard the present and the future. It is my great pleasure to welcome Raluca Radu.
Hi, everyone. Thank you so much. I'll just take a moment to share my screen. And hopefully this is good on your end. Okay, excellent. So, hi everyone, and greetings from Vancouver, Canada. It is a great pleasure to join you here today to talk about degraded air quality and wildfires. But before I dive into my session, I want to take a moment to give immense gratitude and thanks for the land where I have the real honor and privilege to live and work, and that is on the unceded, ancestral, and traditional territories of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and the Tsleil-Waututh nations. So although today's session has quite a lot of ambitious learning objectives, I think for me, my biggest intention, especially coming to you from a nursing perspective, is to ensure that I support you in understanding those deepened health impacts that result from exposure to poor air quality and to wildfire smoke. We know that as I'm speaking right now, actually, in Azerbaijan, the Conference of the Parties, the 29th edition, is well underway, where a lot of the progress that has been made or hasn't been made will be under evaluation and scrutiny, but also we have a large community of health practitioners there advocating for policies that will better prepare the world for adaptation mitigation in the face of a warming climate, especially as the world is dangerously close to reaching its target of limiting those global multi-year mean heating to 1.5 degrees Celsius. So I think it's very timely that we're here today to talk about air quality. When we think about air pollution, though, if we're going to break it down into basics, we really need to understand what air pollution is and what it means for our health and well-being. And generally speaking, when we think about air pollution, we know that it refers to this mix of hazardous substances that come from both human-made sources as well as natural sources. From a natural source perspective, nature generally releases hazardous substances into the air, such as ash and gases from volcanic eruptions. But we also know that nature can release methane, which can be emitted from decomposing organic matter in soils that have been there for thousands of years. From a man-made sort of perspective, we see things like vehicle emissions, fuel oils, and natural gas that heats homes, and byproducts of coal-fueled power plants and fumes that can come from those chemical productions that are the primary sources of human air pollution. So when we really think about what makes up our air, generally speaking, these are kind of like those day-to-day particles that are present in the atmosphere, and the concentration of these particles essentially along with other pollutants such as ozone and sulfur dioxide, which I'll cover in a moment, is what tends to dictate air quality. And in the face of climate change, with hotter and drier conditions, these are increasingly favoring occurrence of sand and dust storms. So those sort of fine dust particles that you see here would essentially become more prevalent and in higher concentrations when we think about the projections over the next years to come. And so, you know, generally there's a lot of toxins that have a myriad of adverse impacts on health, pollutants with the strongest evidence, however, for public health concern that have essentially drawn huge concerns in the scientific community and the health community are the ones that I've listed here, particularly particulate matter, carbon monoxide, ozone, nitrogen dioxide, and sulfur dioxide, each of which has different properties and descriptions, which I've included here for you to reference upon your review when you come back to the slides. But what I wanted to also add is that, of course, there's also equivalent concerns for carbon dioxide, which we know is hugely contributing to the warming of our planet, causing climate change. And human activities have raised the atmosphere's carbon dioxide content by about 50% in less than 200 years. So it really is a gas that's a heat trapping gas, also known as a greenhouse gas, which you may have learned about in the earlier part of the course, that comes from those burning of fossil fuels from wildfires and natural processes. So all in all is to say that each of these major air pollutants play a role in impacting health. And we're going to look at this further when we talk about the more intricate ways in which health is affected. I also wanted to spend a moment to talk about the role of particulate matter as a pollutant of high concern. And there are two types of particulate matter 2.5 and particulate matter 10. PM for short, 2.5 are essentially inhalable particles that have diameters of 2.5 micrometers or smaller. Now, the problem with 2.5 is that it is a severe health hazard as it's actually 30 times thinner than a human hair strand. And when we think about that dimension, we are concerned because the PM 2.5 particles have the ability to cross the blood-brain barrier, which has significant impacts for the health and well-being of populations who are exposed to PM 2.5 in high concentrations. Typically, PM 2.5 sources include wildfire smoke, wind-blown desert dust, and also various type of emissions from different fossil fuel combustion. Well, the problem is that when it penetrates that blood-brain barrier and deep into the lungs, it can really travel to organs all around the body and cause systemic damages to tissues and cells, especially when it comes to the ability for those tissues to properly perfuse. On the other hand, when we look at PM10, which are much larger in size than PM2.5, PM10 includes dust from construction sites, landfills, and agriculture practices, as well as brush or waste burning. Generally speaking, particulate matter has a major impact, not just on health, but also on agriculture, especially crops and the ability for crops to actually grow and be of nutritive value for people who are harvesting them. And so when we think about the areas around the globe that have the biggest impact from exposure to particulate matter, such as Central Africa, China, India, and Pakistan, and Southeast Asia, we really need to understand that the impacts on the population are not just exclusive to respiratory and cardiovascular impacts, but also nutritional impacts as well because of altered crops. And important to note is that according to the Lancet Countdown report that was just launched about a few weeks ago, about 31% increase has been seen in the number of people who are exposed to dangerously high particulate matter. So when we think about the amount of smog, from smog that's hanging over cities to smoke that's inside the homes, air pollution poses a major threat to human health. And these are some of the sources of air pollution that contribute to the different type of pollutants that I listed earlier, from industry and energy and supply to dust, household energy, depending on whether it's clean or whether it's through biomass burning, waste management practices that may not be taking place with appropriate infrastructure in place, as well as other activities. But these are the main ones. And it's important to note that it really does take a collective effort in thinking about how we are preventing and reducing exposure to these type of sources. So another important aspect I wanted to highlight is the distinct difference between ambient, also known as outdoor air pollution, and household air pollution, both of which contribute to combined effects of essentially associated 7 million premature deaths annually, according to the World Health Organization. So World Health, for when it comes to outdoor air pollution, the primary driver in high-income countries and middle-income countries stems from fossil fuel combustion, so coal, oil, and gas. In lower-income countries, the primary driver is the burning of biomass. So sources include residential energy for cooking and heating, vehicles, power generation, agriculture, and waste. And around 4.2 million deaths are attributed every year to exposure to ambient air pollution. Meanwhile, from indoor air pollution, we see sources such as cooking and heating, but most importantly, biomass burning that takes place in open fires and simple stoves, all of which contribute to high concentrations of particulate matter 2.5. That's typically seen from dung, charcoal, and wood as the largest sources. And unfortunately, about 2.4 billion people around the world are exposed to these dangerous levels of household air pollution, especially when we think about cooking with simple stoves or open fires that are fueled by kerosene. And so it really does become more than just a health issue. It becomes a health and equity and social justice issue that we have to consider how these impacts are affecting exposure for people to these combined types of air pollution. Breathing in these pollutants can lead to significant inflammation throughout the tissues, oxidative stress for the organs, and immunosuppression, as well as changing in mutagenicity in the cells throughout our body, impacting the lungs, the heart, the brain, as well as any other tissue that can lead to chronic disease and ultimately mortality. And so when climate change comes in the picture and we consider the different ways in which air quality is affected as a result, with warmer temperatures, changing winds, increasing wildfires in different places or places that have never seen them, as well as new precipitation patterns, these alter the formation, duration, and essentially dispersion or distribution of air pollution. So that what happens is we start seeing things like higher levels of airborne particulate matter that's related to wildfire smoke, or that of droughts, which can also affect the spread of dust and sand, increasing ground level ozone due to warming, as well as increased exposure to mold and chemical contaminants that result from increasing flooding events, as well as more extended seasons and geographical distribution of pollen and increased production of pollen by plants, which means that people who have allergies like rhinitis will end up actually experiencing longer season of allergic sort of reactions and symptoms, as well as warming and changes to precipitation that can essentially affect the growth and ranges of how different aerosol particles contribute to different droplet-borne pathogens. But I also wanted to highlight that besides all of these aspects, climate change impacts air quality through other ways in terms of how health effects are resulting beyond respiratory and cardiovascular conditions. So we tend to see exacerbation of mental health impacts, impacts on health infrastructures and health system service delivery, as well as risk from infectious diseases that can be acquired from inhalation. Altogether, with climate change and a warming planet, we know that heat is of immense concern, as we've seen with growing and more extended extreme heat events that are happening all around the world. But we need to understand that the reason why this happens is heat acts as a chemical catalyst, and it contributes to essentially converting existing elements in the air, so those pollutants that I shared earlier, into ozone and other harmful byproducts. What's of even greater concern is that in highly densely packed urban settings where there's very little tree canopy or grass or any sort of access to spaces that can provide shade, and where you have a concentration of buildings and asphalt that can contribute to how heat is being trapped, so causing that urban heat island effect. These sort of impacts will have a greater effect in terms of lessening air quality with higher levels of smog caused by ground level ozone, which pose a serious risk to human health, especially in the presence of high humidity as well. And as you note in this diagram, we see things like respiratory health outcomes, premature mortality, occurrence of new respiratory diseases, higher levels of ambulance calls, as well as emergency department visits and hospitalizations, to name a few. So when we shift sort of gears to talk about wildfires and the impacts of wildfires, which I think really, I mean, you could spend probably an entire course talking about how wildfires react and how people are responding to their impacts. But it's really important to understand that there's different levels and different causes of wildfires, especially because of improper land management, as well as human activity, both accidental and arson. Unfortunately, however, with a warming climate, climate change in general has an indirect role to play by increasing the frequency of wildfires through the intensity of heat waves that are prolonged, as well as because of prolonged drought that takes place. So in many ways, when we think about wildfires, we need to understand where they're taking place, especially if they're in rural or remote communities or closer to sort of urban centers, and then thinking of ourselves as nurses in the system to consider the kind of access to resources that individuals who may be displaced by wildfires will require in order to kind of have resilience built and to adapt to a new norm in many areas where these kind of prevail over time. They are unfortunately expected to double by 2050, And the pollutants that are contained in wildfire smoke are quite a noxious concoction, a very, very toxic cocktail of different levels of pollutants, as well as the volatile organic compounds and metals, again, depending on the source and the type of fires burning. I also wanted to note that if I were to use an example from my home country, Canada, which has over time seen extended amount of wildfires, but predominantly the one that I wanted to note is from last year, where many large and persistent fires burned from the very first week of May in Western Canada, so where I'm currently living, where it was unusually warm and dry. And those fires started in May and they went all the way into September. That essentially led not only to very, very poor air quality here, but because of different wind patterns and changing conditions in the weather, the Eastern Canadian provinces, as well as Northeastern United States, especially New York City, saw very high concentrations of smoke in early June. And that smoke was transported even across the North Atlantic Ocean as far as Southern Greenland and Western Europe. And this essentially was found to result in total particulate matter and carbon emissions that were well above the annual average, at least for the past 20 years. And that's substantial to note because that has implications not only for people who are exposed to wildfire in the immediate vicinity where it takes place, but also many, many kilometers away. And so what I really liked about pulling this resource from a very recent publication by Hertelendi et al. Was that it's an article that's on seasons of smoke and fire. And what it beautifully does is that it talks about the ways that health systems and health professionals should consider their responses when it comes to preparing for being exposed to and being impacted by wildfires and wildfire smoke. But what I wanted to specifically highlight in this resource that I know will be available to you once you access the resources according to this session is the impact on health. So when we think about impact on direct trauma from fire, so the higher the proximity one has to fire, the larger the risk for burns, for injuries, motor vehicle accidents, because there's very poor visibility when you're trying to drive around with smoke around, and death. And this direct trauma can be especially more challenging for people who are living in rural, remote places who may not have access to large medical centers that can provide burn and trauma care to victims who are affected by burns. But wildfire smoke exposure can also contribute to various respiratory and cardiovascular health effects because the toxicology of wildfire smoke from particulate matter 2.5 can be very different than toxicology of PM 2.5 that's generated by other sources. So essentially, there's no safe time to be exposed to wildfire smoke. The effects can be as immediate as in the first 5 to 15 minutes that you're outside. And so it's really variable in terms of the types of fuels, fire, and weather that's contributing. Moreover, in the short term, for nurses, it's important to understand, as you'll note in this diagram, and the acute, the medium term, and the emerging long-term impacts on health. So in the acute short-term period, we see immediate effects on respiratory health, especially for people who have pre-existing respiratory conditions, such as chronic obstructive pulmonary disorder or other pulmonary diseases, as well as immediate impacts through headaches and watery eyes, as well as a decrease in mood, things that I can attest that I've experienced when I was exposed to wildfire smoke. But we also see a high correlation of cardiovascular events, especially out of hospital cardiac arrest, suspected impaired diabetes control, and essentially exacerbated kidney disease and overall altered cognitive function. As we look to the long-term exposure to wildfire smoke, we start to see things like an increase in the way the mental health is impacted from post-traumatic stress disorder, especially among people who have been displaced, ecological grief and eco-anxiety, particularly present in youth and children, as well as impacts on developing fetus, newborns, as well as women who are pregnant who may experience preterm birth, as well as having babies with who are not substantially developed or come to term. At the same time, I would note that in studies that have been done in Canada for communities that have been predisposed to exposure to a wildfire smoke have experienced longer respiratory influenza seasons because they were affected by wildfire smoke during the summertime. And so again, it's those impacts that may not be as visible, especially things like Indigenous peoples experiencing substantial disruption to land-based practices, which can thereafter contribute to very poor mental health outcomes in the long run. And this image sort of builds on the previous one because the framework that's being proposed in this study, which again, I highly encourage you to have a look through, is a timeline-based approach to how we consider our health system's ability to prepare for wildfires. So those time periods that the authors sort of highlight are mitigation. So what can we do throughout the year before we anticipate the start of the season? What can we do right before the season starts? So the preparedness side, the during response, and then the recovery, which is the after phase. For me, I wanted to highlight the before, and I specifically circled in red the areas where I think that nurses can play a role in impacting decision-making, impacting clinical practice guidelines, as well as preparedness for colleagues. So we think about the kind of air quality monitors that facilities and maintenance can be responsible for installing to ensure that our building envelope is prepared and has adequate ventilation, but essentially also making sure that there's a community stock of essential medications, especially if we anticipate any disruptions in our supply chain. If we're living in communities that are more likely to experience potential displacement, or if we're living in communities where we anticipate receiving more influx of patients coming through our hospital doors. It's also making sure that patients who are vulnerable are paired with professional supports in case there's evacuation, but making sure that capacity building is taking place in terms of running evacuation simulation exercises with staff, and again, making sure that reusable supply options can be processed in the community. So it's really going through what we call a stress test of the health system for the ability to take on an increased patient load. And I would argue that actually this kind of framework could work very well when we think about similar events during extreme heat temperatures in the summer. So thinking about what are the kind of mock simulations and codes that we can prepare our staff and ourselves for responding, and consider the kind of roles that we play at that micro and meso level within the system itself. So moving forward to thinking about health and equity in terms of exposure to poor air quality, really when it comes to air quality and disease burden, I often get this question as to how long does someone need to be exposed to air pollution in order to see a harm to their health. And again, as I mentioned earlier, there is no sort of safe window or parameter that says that it's okay to be outside for this amount of time when the air quality is showing poorly. And so as you'll note in this graph, air pollution is at the very top in terms of contributing to global disease burden as was measured in 2021. As well as the outdoor particulate matter pollution that people are exposed to. And again, these are because air pollution tends to be seen as the silent killer, the invisible sort of killer. It's very difficult sometimes to understand the different other ways in which it hasn't been studied and how people's health is affected, especially when it comes to problems that are seen in children and adults because of both short and long-term exposure. And so both levels of duration of exposure can be varied in terms of the different types of diseases that they contribute. And for some pollutants, there are no known thresholds below which adverse effects are known to occur. And so returning back to those air pollutants that I talked about in the earlier part of my presentation, and what exposure to each of these means and looks like for our health, taking, for instance, particulate matter, as I've said, both short and long-term exposure is associated with morbidity and mortality. And long-term, we know that it contributes to chronic lung disease as well as adverse perinatal outcomes. For carbon monoxide, ozone, nitrogen dioxide, and sulfur dioxide, you may see similarities in how exposure is associated with either increased emergency room visits because of asthma being exacerbated, because there's more episodic sort of inflammations in the respiratory tract, or we see those sort of irritated airways and exacerbations through respiratory conditions such as COPD, which may require additional sort of medication and monitoring within hospital settings. Ozone, especially because it's one that is even more prevalent in the form of ground level ozone during the summer, as I've mentioned, when you have a combination of both poor air quality and also extremely hot temperatures, those can pose significant difficulties for individuals who are living with respiratory or cardiovascular conditions, who may be coming in with shortness of breath, or pain or discomfort on breathing, as well as having those symptoms such as wheezing and coughing that you would come across through your health assessments that you're undertaking, either within your public health unit, your community clinic, or in the emergency department. So thinking about what kind of role do we play in mitigating and ensuring that the comfort is brought to the patient beyond just that clinical response, but also the one that we provide that sort of longer term comfort when it comes through education with the patient that I'll talk about towards the end of my presentation. And generally, what I wanted to note about exposure to all of these air pollutants is that typically there's an overlap in respiratory cardiovascular effects and responses. And we see patients essentially often returning to emergency settings with recurrent visits within a defined sort of period of time, especially if they've been kind of walking outside and have not had any access to, for instance, N95 respirator masks, or other means to ensure that they're staying away from poor air quality. And so this brings me to really highlighting how compounding impacts on vulnerability, on what this kind of looks like in terms of people who are affected. So we know that genetics, comorbidities, nutrition, as well as sociodemographic factors impact a person's susceptibility to air pollution. People in the sub-Saharan Africa, Southeast Asia, as well as the Western Pacific are known to be the ones to experience the highest rates of health problems that come from exposure to indoor and outdoor air pollution, especially when it comes to the type of household energy that's being used. And at the same time, within these specific geographic regions that I've mentioned, the burden of the disease tends to fall most heavily on rural households. Because they are known to kind of lack the resources to obtain cleaner fuels and devices. And people in lower income households typically rely on fuels that they can freely gather, such as wood and dung, and more traditional inefficient cooking stoves. Unfortunately, at the intersection of this, we find women, children, and the elderly who bear the brunt of the household air pollution because they are known to perform these domestic tasks, to be the ones who are spending the most amount of time in these settings. And so they're going to have that exposure factor much more elevated, as we've seen. But also notably the people who experience marginalization in society, as well as who experience homelessness, who are displaced for various reasons, such as conflict, children, the elderly, athletes, as well as outdoor manual workers, all are having higher levels of vulnerability when it comes to poor air quality. I also wanted to make a note about Indigenous communities, as I've alluded to earlier. Especially when we think about the fact that, as this quote says, Indigenous peoples don't just belong to a place, rather they see themselves as embodying place itself. So again, it's that intricate relationship to land-based practices that we've seen in groups who live in remote villages around the world, who are really highly dependent on the land for survival and for feeling like they have a sense of belonging. So when that is disrupted because of a wildfire, because of being forcibly displaced as a result of increasing climate impacts, that carries immense intergenerational traumas and mental health outcomes that last for many, many years. Additionally, when we take a closer look to the impact of air pollution on children's health, a child who's exposed to unsafe levels of pollution can really face a lifelong sort of impacts when it comes to how they grow and develop. So depending on how young they are when they're exposed to poor air quality, we see anywhere from stunted lung growth to reduced lung function to increasing sort of recurrent acute lower respiratory tract infections. We see more risks for premature birth, childhood cancers. And importantly, because of various longitudinal studies that have been done, there's been reports as well of increased risk of heart disease, diabetes, and stroke further along in adulthood. So although this image is from 2020, I do want to point out that the figures are quite staggering in terms of the number of deaths in children under 5 years old, as well as those in 5 and 15 years old as a result of being exposed to poor air quality, both indoors but also outside. And so I cannot emphasize this enough that it's unfortunately air pollution may not always be visible. It really is one that doesn't have any borders whatsoever, but really does have impacts on people who experience highest levels of vulnerabilities across lower and middle income countries, but also those people who are the ones who have least contributed to the climate crisis. So it's really important to consider what kind of role do we want to play and take on when we're practicing in diverse communities and roles in order to ensure that these harms are reduced. So we start to think about some of the guidelines and the supports and resources that we have access to. First and foremost, the air quality guidelines, which have, I believe they've been implemented in around 2021. They were set by the World Health Organizations as targets for national, regional, and city governments that are both based on evidence, but also that are meant to support working towards improving individual and population health, because about 99% of the population around the world lives in areas where air pollution is well above World Health Quality Air Guidelines. So it's really important to consider, as you'll note in this diagram, the previous 2005 short-term air quality guideline levels versus the ones that have come from 2021 over recommended 24-hour time period. So what is deemed to sort of say safe, I like to use kind of lightly in quotation marks in terms of exposure to the various pollutants that I've listed in previous slides and that you'll note here on this slide in terms of particulate matter, ozone in an 8-hour time period, nitrogen dioxide, sulfur dioxide, as well as carbon monoxide. So it's really, they're meant to really help set interim targets that help countries to continuously work towards improving air quality, but also work towards recommending air quality guidelines that are meant to protect people. The other thing that I would highly encourage you to get familiar with is the Air Quality Index. And honestly, the one that I've pulled here is from the Environmental Protection Agency from the United States, because I really like how graphically it showcases both the daily AQI color, the level of concern, what is the value of the index, and most importantly, what is the description of the air quality that I can use in my teaching moments with patients when it comes to trying to kind of explain to them when it's safe to be outside and when they have to start considering wearing a mask or reducing their exposure. As you'll note, it helps to see in real time how polluted or clean the air is, as well as these scores are based on main air pollutants that we previously discussed. And another neat tool that I wanted to also pull, this is a screenshot I've taken last Tuesday, and it's if you go on IQ Air, it has the ability to pull the air quality live as we speak from any parts around the globe. And as you'll note right here, the legend kind of uses a similar approach to the air quality index graph that I just showed in the previous slide. And lists sort of the cities, the list is much longer of how the air quality is doing. But as you'll note, there's also signs with fire, which shows you where there are active fires burning around the world. As you'll note, again, as I've mentioned earlier, the countries and areas around the world where from a socioeconomic perspective, individuals experience the highest burden of disease and vulnerabilities are also, at no surprise, listed on this graph as experiencing air quality that is absolutely beyond what's safe to be exposed to from both an indoor and outdoor perspective, especially when it comes to the very unhealthy and hazardous sort of levels. And I think if you are, I believe, if I'm not mistaken, you can also download something like this on your phone as an application to kind of see and check every day how the air quality is. And I think that can come in very handy if you're having a patient visit you during practice hours to talk about exposure to what's safe and what isn't. And so I think it's a really neat teaching tool. Lastly, I wanted to spend the last few slides of my presentation talking a little bit about recommendations for practice consideration through the ecological planetary health model, which really does highlight that interrelationship and multiple levels of influence that nurses have on behaviors and actions to address health of our planet. So all of these climate strategies that you see listed in terms of the different sections have an ability to influence interventions at every single level. And I wanted to specifically sort of use this beautiful diagram that's been done by my amazing colleague, Dr. Courtney Howard, to talk more about the micro, meso, macro and what it means to kind of have an aspect that triggers a signal for change. So I would argue that the fact that you're here has triggered a signal for change in your practice and how you're wanting to build capacity and literacy on climate change and health in order to bring that knowledge into your practice. But you also have to kind of consider what is in my immediate sphere of influence? What are the kind of structural barriers that are in place right now that I need to know about in order to ensure that I can move from inaction to action? So first and foremost, we try to start with that micro, that individual level. And I would say that you've already done that by being a part of this course altogether. There are many things that we can do at the individual level, and I will not talk about the mitigation aspect of the footprint because I think for the purpose of this session, it's more important to really consider our role in adaptation and resilience building. So that means that how do I engage my immediate community, my community of colleagues, my community at home, in order to ensure that I'm helping to support to shift the narrative at the macro, the national level when it comes to not only the footprint, but generally when it comes to our health system's ability to build adaptation as a part of its responses on a recurrent basis, on a year-end sort of basis. And that all together, when we start to see clinical teams and healthcare systems specifically engaging in small scale or large scale projects, it starts to really shift the narrative in the community. And that starts to be heard at regional, local governments, and to start to think about how we're changing our policies, our subsidies, and our investment to ensure that we're shifting away from fossil fuel combustion in order to improve air quality for all. So it really is about how we use our narrative to instill concrete change and success stories and to build behaviors that are reflective of a way of caring for patient and planet all at the same time. And so to break it down further, I wanted to kind of give examples within all those different spheres of influence of the ecological model for planetary health. From the individual, like I've said, I really believe that nurses could have a huge contribution in when you understand the air quality index and kind of what the air quality guidelines are about. I think that those can be instrumental tools to use during clinical teaching moments with our patients. So really understanding what is happening outside and how can I relay this to my patient to ensure that their health is not harmed. Undertaking comprehensive health risk assessments. So I know that nurses do beautiful assessments already, but how are we taking that to the next level in terms of the interrelationship with what the patient is being exposed to when they're outside the hospital or when they're outside the clinic setting? So again, optimizing patient teaching opportunities. I think that from an individual perspective, we can also advocate for improving housing or portable air filters for people who experience vulnerabilities and marginalization. and for making sure that our health facilities have upgraded HVAC systems essentially in our buildings to ensure that the envelope is protected, especially when it comes to potential exposure to wildfire smoke. From a community perspective, I think we could have a beautiful role to play in essentially promoting active transportation, especially when the air quality index points that it's a safe condition to engage in walking and cycling and biking, in trying to rely less on public transit and more or on individual car use and more on active ways to getting to and from work. It can be very rewarding to get involved in city council, municipality policies to support urban planning policies that are done through a health forward lens. I really do believe that health providers, especially nurses, could have a really incredible role to play at that intersection, especially also thinking about what kind of role we play in primary care settings and public health units. Especially if we are able to go into local schools and talk to kids and youth about things like ecological anxiety, to talk about things that can help them protect themselves if the air quality outside is poor, and really find engaging ways to stay connected with the community. From a regional, national perspective, I believe that if every health facility were to undertake a climate change, health vulnerability, and adaptation assessment, it would be immensely beneficial for the long-term planning for facilities, not just in terms of exposure, potential like exposure to wildfire smoke, but also in terms of extreme heat events and in more and more climate-related emergencies. At the same time, if we were to advocate for grassroots initiated communities of practice that represent our geographically diverse regions and make sure that they have inclusive places for each person in that society, it would be a very more comprehensive sort of response when we think about adaptation. At the same time, I think we could play a role as nurses in advocating for the implementation of climate change and health-related education across all nursing curricula. And I will argue here that it should not just be done at the undergraduate level, but we should have a mandate to do so at the graduate and doctoral level as well, because there's different tiers of roles in which nurses can take responsibilities in enacting change from a climate and health perspective. From an international perspective, I still think there's plenty of ways to get involved. I've been very grateful to join transdisciplinary communities of practice, such as the Global Climate and Health Alliance, the Planetary Health Alliance, Healthcare Without Harm, all these organizations that have an international sort of voice and where nurses also are represented. Importantly, I also wanted to point out two documents that I've included in my resources, both developed and produced by World Health Organization. The first is the Operational Framework for Climate Resilient Low Carbon Health Systems, which is a great sort of framework that talks about how health systems can start considering their roles in preparing their facilities and staff for increasing climate change events. And the second one is on supporting health professionals to communicate on climate change and health. So it's a really neat toolkit that I highly encourage you to have a look at. In closing, my last takeaway is to say that when we, and by we, collective nurses together with our colleagues in other health disciplines, engage in both adaptation and mitigation activities, both of these carry immense health co-benefits. And I've included an example, for instance, that in the European Union, between 2015 and 2018, when they try to address air quality by closing a lot of their coal power stations, they saw health savings in the equivalent of $8.8 billion US. When we think about the kind of economic benefits that can ensue when we engage in adequate adaptation mitigation benefits and activities, then we understand that that funding can be used towards ensuring that our health systems are prepared, that we're able to support our schools and communities in ensuring that they too develop the adaptation necessary to ensure that they have resilience in the face of climate change, but altogether in ensuring that both morbidity and mortality are reduced in our populations. Thank you.
Thank you so much, Raluca. I am going to go to the Q&A and ask you a couple questions that some of our viewers have listed. So the first one is, do you think people are less willing to wear masks to protect themselves from pollution since COVID, given the politicizing of mask wearing? How can nurses promote mask wearing and use of portable air filters?
Thank you so much for that question. And I apologize if you hear an ambulance in the background. So I think that's a really good question. I think that if it's really all about how we use our narrative and how we really position ourselves, I think nurses have a really we undervalue our role that we have in society because we are very well trusted by the public. And so I think we really just have to use that as a leverage in terms of how we communicate why the wearing of masks specifically can be helpful to prevent exposure to pollutants that can be very toxic. So really using very lay language can often be more helpful. But the other thing that I would mention is that sometimes it's also helpful to ask the individuals, the patients, what may be contributing to their sort of hesitancy. Sometimes people may feel embarrassed to wear masks, or they may feel like they're being judged by their kind of immediate community. And so I think that if we are able to tap into an example or a person who is wearing a mask and to use that as a way to relate to your neighbor, I think more people would be able to be on board if they understood that it's not for COVID, let's say in this case, it really is to prevent chronic disease happening over longer periods of time. So typically I try to work with local examples and even ask, like, what do you know about your neighbor? Does your neighbor have a portable air filter? Like, is this something that you could connect your neighbor about? Because it's also making sure that we're contributing to building community. We need people to be in spaces where they have strong cohesion, especially in the face of more climate-related events taking place.
Thank you. Yeah, wonderful recommendations about communication to patients and our communities. Another question in the chat is, how can poor air quality increase the chance of stroke? Can you please elaborate on this?
Yes, so from my knowledge about this, as I've mentioned earlier, because particulate matter 2.5 specifically, I have stipulated that it's about 30 times thinner than a hair strand. So when we think about how microscopically small that is, and again, depending on the levels of concentration that someone is being exposed to, that specific particle, when it crosses the blood-brain barrier, it triggers an inflammatory response in the body. And we know for a fact that when we have generalized inflammation of our tissues, when we have tissues that are poorly perfused because of lack of oxygen getting to them, this is even more so exacerbated, especially in patients who may have, if they already have hypertension or they already have plaque buildup in their arteries. Any bit of inflammatory response can trigger potential blood pressure that increases. And if there's a blockage, we know for a fact that that plaque can essentially dislodge and contribute to stroke or an infarct per se to that tissue. So it really has to do with the connection with PM 2.5 leading to chronic inflammation.
Thank you so much. Another question, curious to know if nurses working in long-term care homes have a different role in terms of adaptation and mitigation with wildfires and air quality.
That's such a good question. I would say different in the sense that sometimes, depending on the residential facilities and what the capacities for, I know that in the pandemic, we have seen an exposure on residential facilities, at least from a Canadian perspective, that was quite morbid in terms of what resources people had access to from, like an infection prevention control perspective. I think that one role to play as beyond just, getting in touch with the facilities management, people who are actually in full responsibility of the facility and asking about the envelope and making sure there's air quality monitors in place. The other thing would be to ensure that those health assessments that we are very much responsible for undertaking for our senior residents, to make sure that they're being done on a regular basis. I know oftentimes in long-term care, because not only is there such a high a ratio in terms of the number of patients that nurses care for, but also a large amount of residents to get through. oftentimes assessments get missed, or they're just resumed to only vital signs only. And I would argue that a huge role to play would be to ensure that that baseline assessment is done every single shift, to ensure that there's no change in the patient, especially if you are working in an area where your community may be predisposed to wildfire smoke during specific seasons, and also to extreme heat, in being really able to recognize if there's a change in that resident's health status, not just from that baseline, really going beyond the baseline vital signs, which unfortunately, because of a lot of competing priorities nurses face when they work in such busy settings.
Thank you so much. How can we best avoid public pollution caused by moving vehicles and industries? How can the healthcare industry help reduce such emissions?
Oh, another great question. So I feel like I could answer this in two different ways. First of all, I think if we're talking about avoiding, or I think it's kind of not realistic to say that we can fully avoid the air pollution that's outside. I mean, we have to go outside, we have errands to run, but I think what's important is if we were to start our day making sure that we check the air quality outside to really understand what kind of pollutants are outside, using that IQ Air. Sometimes I know the different phones, Androids and smartphones in general, have access to telling you the air quality. And if you recognize yourself as someone who has a pre-existing condition, understanding that you might need to take an additional layer of protection when you're going outside, even if that may entail wearing a mask. The aspect about the health systems contribution, we know that healthcare systems in general also contribute to climate change and to a lot of the medical waste and practices that are emitting noxious gases in the atmosphere, but also through the practices in hospitals. I think, as I've said, when we undertake pledges with our organizational commitments to setting specific targets to reduce waste and to ensure that our health systems take the pledge to have strong adaptation simulation protocols in place and policies, as well as to mitigate their footprint. And I'm proud to say that in the Canadian context where I work, a lot of my colleagues and our organization where I work has set those targets. You start to sort of shift the needle in terms of what you can do within your sphere of influence. And I would say that it doesn't have to start at the national level. It can start within a community clinic, but make sure that you use that narrative to share what you're doing, because I think we need to amplify our communication of these stories to help other sort of people start taking on that ripple effect. I hope that helps.
Thank you so much. And I think we have time for about one more question. So kind of piggybacking on what you were just talking about with communication, how can nurses enhance their climate messaging and articulate the dangers of climate-induced degraded air quality to diverse patient audiences? How can climate messaging be redefined within discussions?
I think nurses are incredible in terms of where they're positioned, as I've said earlier. And I would suggest that at every given time, whether you're in a clinic with a patient or whether you're in your hospital setting and you happen to be that one champion that really cares about planetary health, about climate change, really use any nugget of knowledge that you have read in an article. Like even from today, I would challenge any participant in the session to go back to your colleagues and share one thing that you've learned today. Any little piece of information that you can start to talk about and bring it in that sort of norm is really important. The other aspect I would say to nurses is to become comfortable speaking with the media. I've really enjoyed being able to engage with media over time, whether it's through doing different podcasts for at the university level, or whether it's going on the news during wildfire smoke seasons to talk about the health impacts of wildfire smoke, but really taking that through a nursing stance and saying, I am a nurse and I am concerned about this because these are the different type of health effects. When you bring that positionality and you talk about it through a nursing lens that you so well hone in on, I think people are going to start to understand and to really put more value towards that because it's coming from a nurse. So any tips on how to engage with media? There's typically a lot of free courses out there that can help provide tips on how to engage during those sessions, but also to try to join in on presentations at conferences and be able to kind of widen your network in order to ensure that that nursing voice is present time and time again. And if you haven't been invited, bring a chair and sit at the table anyway.
Thank you so much. Thank you to all of you for joining today from around the world. Immense gratitude to Raluca Radu for sharing her tremendous insights today. As a quick reminder, all of the video recordings and important details are located within our course website. They've also been linked in the chat throughout the talk today. So please check that. The video recordings specifically are on the Annie platform, which is on our course website. It's linked there. Please join us again next week for session 8 in this series on heat-related illness with myself, Dr. Karen Duderstadt, and Dr. Gina Friel. Take care, everyone. Goodbye. Adios. Adieu. Auf Wiedersehen. Have a good day.